Good evening, I'm Dr. Maccabee. Tonight I'm going to be giving you an educational talk about weight loss surgery and what we do at the Weight Loss Surgery Institute of the Central Coast. That is a bariatric surgery program here in Santa Maria Hospital, Santa Maria Marion Regional Medical Center, and the program has been developed and built by myself and our nurse Carrie Smith over about the past 5 years, and these educational lectures, which are for patients and family, are designed to make sure that you know everything you need to know about surgery. This way, when you come and see me in person, we can talk and have an educated discussion about what it is that we're trying to do. So there will be patients perhaps coming in during the time while we're talking, and I'll just welcome them. Just came in through the back door is Dr. Dawes. Tom, welcome. I'm actually going to put you on first. Okay. Now, Dr. Dawes is a medical doctor who helps us with our medically supervised weight loss program. So not only do we offer surgery, but we also offer supervised diet and occasionally medical therapy. Tom, my laptop was stolen last week, and all of the changes to the talk that included your intro are not here tonight because I haven't rebuilt it. So you're going to have to go extempore. We're also videotaping for our YouTube educational program. And so with that and no intro, this is Dr. Dawes, who in a couple minutes is going to tell you about what he does in the medically supervised weight loss program.
Great. Well, thanks, Dave, for having me in. I'm the newest joined to the team, and I'm a family physician who has been specializing in medical weight loss. I've been part of the center now for about a year. And what I do is look at different patients who may or may not be interested in surgery with Dr. Maccabee. What I offer is we can look at medications that we can try for weight loss. I also run a medically supervised weight loss program which uses Ideal Protein, which is a food product line that helps you lose weight pretty rapidly, about 3 to 5 pounds per week. And it's a nutrition lifestyle campaign that basically looks at all aspects of your life, and it goes through how to shop, cook, provide for your family, and wow, I'm here. So basically it wouldn't be surgery. We're looking for people who have a BMI, and Dr. Maccabee is going to go over that with you, a body mass index of about 35 or below. And we can use the program for pre-surgical patients or patients that are going to have surgery, or for patients that want to try medically supervised weight loss on their own. In addition, I'll go over many of the other conditions that happen when you have obesity, including diabetes, high blood pressure, sleep apnea. And we'll look at all of the other conditions like dyslipidemia, cholesterol issues, and we'll evaluate those for you. I can get you referred to our dietitians, so we have dietitians in the center, and we will be doing psychological evaluations with clinical social work. Once we've gone through all of that and you become a candidate for medication, I'll be managing medications for you for weight loss as well. We're developing a program to that end. At any point, if you decide that bariatric surgery is where you want to be, we will get you back in with Dr. Maccabee to do so. So essentially, I can work in conjunction or directly with Dr. Maccabee for working with his aftercare program for his surgery patients, or I can work with you prior. And I've left some cards over there, and I'd be happy to see any of you in consultation, or if Dr. Maccabee determines that you're not a surgical candidate or not interested in surgery right away. So, any questions?
Thanks very much, Tom.
Thanks. Hey,
appreciate it. That was excellent timing.
All
right, here we go.
Enjoy.
Oh, yes, sir. Back to here. Go to here. Okay. So, in the next 45 minutes, we're going to talk about what is obesity, what is surgery, who qualifies, what are the operations that we do, what are the risks and benefits of surgery, what is our program, what does surgery cost if you're having surgery out of pocket, what are the steps to have surgery, what is an emergency that you need to call me about. The bottom line why we do surgery is this. This is what you look like, or some patients might look like before and after. Now Jeannie, those are her real pants. This was a year and a half after her gastric bypass, 125 pounds. She's one of the first patients that we operate on. I haven't seen her in a couple of years. Actually, I haven't seen her in 1 year, and she's doing great. In order to know if you can have an operation, you have to know your BMI, your body mass index. It's your weight divided by your height squared. It's a number that accounts for how tall you are. If you come in and you don't know it, I'll just figure it out on my iPhone, just type it in, but you can figure it out yourself. You have to have a BMI more than 35 to qualify for an operation. So for me, I'm 6 feet tall and I'm 185 pounds today. So my BMI is about 26. So insurance wouldn't be interested in offering me an operation because my BMI isn't over that threshold of 35. You have to have a BMI of more than 35 and a medical problem related to it, or a BMI more than 40 and no medical problem necessarily. If your BMI is between 35 and 40, in general, you have to have either diabetes or high blood pressure or sleep apnea anymore. Sometimes reflux, sometimes there's other things we can use to help justify a surgery. There's a bunch of other less common medical problems. If your BMI is more than 40, then insurance companies are usually interested in offering you an operation because in the long run, it makes you healthier and actually saves them money. That's the idea. In California, where 10 years ago 60% of our population was overweight or obese, we're in good company. It's not like this is an uncommon thing anymore. In Santa Maria, where we are, there's 100,000 people. 70% of those people are Hispanic, and 70% of the overall population there is overweight or obese. So that means about 50% of the Latino population and about 30% of the white population of Santa Maria itself is overweight or obese. If you look at San Luis Obispo County, which is to the, this is the county as opposed to the city statistics, 2009, 20% were overweight or obese. It's a slightly thinner population there, but still that's 25% of the population is people who are theoretically wanting to talk about weight loss. So how do we get here? Why are we fat? What's wrong with this slide? Anybody? Yeah, so the dog's getting exercise, but the guy in the truck isn't. So I took this with my iPhone on Pismo Beach last year. I thought it was hilarious, although it's not really funny, right? So we're big for a lot of reasons. We don't exercise enough, most of us. It's really easy to get calories. You know, this person never got out of the car. So first they took the dog for the walk on the beach, right? And the dog hopped in. They went to the drive-thru and got 2 double doubles and a big animal fries. And so that's 12 or 1,500 calories, which is really all the food you needed in a whole day, but that's only one meal, and you never even got out of your car to do it. And then we drink too many calories too. So the Trenta latte, whatever this super Starbucks drink is it's literally the size of your stomach, and that's almost 1,000 calories. I think there's 900 calories in those. And that's what you got between breakfast and lunch, right? So we generally eat more than we need to, and we exercise less than we need to. How do you lose weight permanently? Well, the truth is there's no real fat buster pill. There's no diet that works permanently unless you keep doing it. This is a picture of Dr. Oz testifying that one of the pills that he was selling on TV was only a short-term solution and not a real long-term diet aid. In general, we already know this. How do you lose weight? You eat less and you do more. Duh, we know that, but it's very hard to actually do that in real life when your brain is saying there's good food, let's eat. Surgery does help you eat less. Surgery will help you curb your appetite and it will make it more uncomfortable for you to overeat. But what surgery does not do is help you do more. It does not make you exercise. Surgery is not going to change your exercise or lifestyle habits. The Wellness Center next door, which you guys all walk through, which is the gym and physical therapy and rehab facility attached to the hospital, is available to all of our patients. And either John or, well, Joel's gone now, but John or his new partner will help you with learning how to exercise if you don't already know, or how to do work with your body that you're not used to doing in order to have success. So what's wrong with being big? What's wrong with obesity? Unfortunately, all of these medical problems are related to that. So it shortens your life. The average life expectancy of a patient with a BMI more than 40 is several years. I think it's 8 years shorter than someone who's lean with a BMI of 25. So you actually live less, and while you're alive, you have more problems. Blood clots in your legs, arthritis in your bones, usually knees and ankles are a big problem for people. Type 2 diabetes is the biggest one that I see. Like 3/4 of our patients have diabetes and are on medication for that. High blood pressure is another one. I forget where it is. It's somewhere over here. And that leads to heart attacks, breathing problems, including sleep apnea with need for a mask at night. Anybody here have sleep apnea and use a CPAP machine? About half the hands are up. High cholesterol, arthritis, limited mobility, all these different medical problems are related to being big. And when you lose weight, most of them get better and sometimes go away completely. So this slide from more than 10 years ago showed that morbid obesity has what I just said, significantly increased mortality, high blood pressure, sleep apnea, diabetes in red because that's the biggest thing that we see, lipid disorders, degenerative joint disease, causes fertility issues in women, and one of the big things that I'll emphasize to all women who are still having periods is that you need to use birth control after surgery for at least the first year because it is likely you will get pregnant even if you weren't planning on it or even if you've had trouble getting pregnant in the past. I've lost count, between 8 and 10 babies born to our patients in the past couple years who lost weight and then successfully got pregnant. 16 years ago, obesity was the #2 cause of preventable deaths in this country. It's now higher than that. It was very expensive for our country, cost $150 billion in 2008. That's all of the associated expenses with taking care of the medical problems from obesity, and those numbers have only gone up as well. So there's lots of information that shows that surgery pays for itself. If you pay for surgery up front, you get the money back plus more down the road as medical problems get better. So that's why insurance companies and even private healthcare organizations like Kaiser Permanente are interested in paying for these operations in order to save themselves money by making you healthier. Why do we do surgery? Why not do something else? Well, the truth is that only surgery has proven effective over the long term for most patients with morbid obesity. You can't read the fine print probably, but this is the 1991 consensus conference from the National Institute of Health. Those are the people who advise Medicare, and which makes Medicare rules. That was the conclusion in 1991, and every subsequent conference since then. So 95, 99, 2003, all the way to now. So this is a picture of a great big huge guy having an operation like 30 years ago. He's having a gastric bypass in the 70s, and we're still doing essentially not exactly the same operations, but we're still doing surgery because there isn't a better solution. Why don't diet and exercise work? How come all those other things that we try don't really work? The truth is that I don't actually know. Being obese is a complex problem. Our brains are wired to pursue food. It's in our brainstem. It's like food, shelter, and sex. That's what your brain wants to pursue. And you can't just turn that off. And we all have taste buds, and we like things that taste good. And as I said, we live in a society where it's easy to get calories. They're cheap. They taste really good, and you don't have to do a lot of exercise to get them. Our guts actually make hormones that increase and change our appetite. Has anybody here ever heard of ghrelin? Anybody ever heard of that hormone ghrelin? So ghrelin is a hormone that's made by your gut. And this is a study from the New England Journal from, well, it's 2011 now, where they looked at 50 people who didn't have diabetes, who were obese, and they put them on a diet. So they had all these people, and they put them on a diet, and they all lost some weight. I think it was about 10 pounds. Forget exactly. After 10 weeks, they took them off the diet. And when they were on the diet for 10 weeks, their weight went down, and that ghrelin hormone level went up. So go on a diet and lose weight, and the hormone goes up, which is your appetite hormone, right? Lose weight, appetite goes up. Does that make sense? Then they went and looked at them a year later when the diet was over for almost 40 weeks. And a year later, guess what? The hormone levels never came down, stayed high. And everybody had regained their weight plus a little bit more. So lose 10, gain 15, right? And then you do another diet and you do it again. Lose 15, gain 17. So every year, you're actually gaining weight even though you're trying to lose weight. That's called yo-yo dieting. Have you guys, anybody do that? So the repetitive lose weight and gain more weight cycle is what surgery helps you break. So this is a picture of a patient I operated on when I was in Oregon in 2000 and something. He had a gastric bypass. He was a policeman. He couldn't get in the car. He couldn't get behind the wheel, had a big belly, couldn't get his duty belt on. He had a gastric bypass. After 8 months, he's lost almost 100 pounds. A year later, he's at 200 pounds. Normal guy in a t-shirt, you can't see his scars. And he decided he didn't want to go back to policing, and he became a semi-pro golfer. But why do we do surgery? Because surgery really works. Surgery really changes lives. And the diet and exercise programs that most people have been through don't often work that well. So this is another real patient. She's from here, from I think 2 or 3 years ago. And you can see here's her before picture. After her sleeve operation in 12 months, she lost 96 pounds. So that's before. And she took a picture of herself every 3 months. So that's a year later. And then a bit after that, along comes the baby. So as I said, women who can get pregnant have a greater likelihood of becoming pregnant after this surgery, although we don't call it a fertility operation. So why do I do surgery? I do surgery because I like doing it. So this is me doing a gastric bypass in 2003 with a mentor of mine, Dr. Devaney, who's retired now. We get to use flat screen TVs and fancy tools and little tiny trocars. For me, surgery is fun. For the patient here, maybe not as much fun, but the bottom line is we do surgery for morbid obesity because only surgery works. And this is me doing that same operation here a couple years ago, 10 years later. So although we're always trying to innovate and find and do new things, we haven't found a better solution than the gastric bypass, which is still the mainstay operation that we use, although I do a lot of sleeve surgery now as well. This is another real patient from Oregon. Beforehand, 420 pounds. He has diabetes, high blood pressure, and sleep apnea. He's so big he can't get out of a bed without a bar to pull himself up on. You can see he's got a great big belly that's covering his privates, and that makes his hygiene difficult. He's in a wheelchair part of the time. He had a gastric bypass. This is him in the recovery room with little incisions that have little Band-Aids over them. And a year later, actually not even a year, 6 months later, his skin is like a balloon that got stretched and can't stretch back. So he's left with a big extra skin envelope that is called a pannus. We call that pannus. And it got kind of inflamed at the bottom. Taking that off is called a paniculectomy. Most people call that a tummy tuck. I do a lot of those. Today I did 4 gastric bypass surgeries and a paniculectomy. I do about 1 a week anymore as patients come back to us years later. And that's what his tummy tuck scar looks like. And a year and a half after that, he's gone from 420 to 260, so he's lost 160 pounds. His blood pressure's gone, sleep apnea is gone, diabetes is gone. He's off all of his medications, and he's a normal guy in a shirt, even though he has that big belly button scar. And he brings me a big bag of mushrooms anymore every spring because he's out in the forest running around, because he's normal again. That's the point. He's not in a wheelchair anymore. Another patient from here from 2013, May 2013, 290 pounds. She had a gastric bypass before and after. Same patient, no more surgery. Another before patient, she's kind of a jokester. She likes that one. 240 pounds before her sleeve, 144 pounds after her sleeve. She had a tummy tuck too. Some people do that, most people don't. A lot of times I don't recognize patients when they've come in later. So March of 2014, 260 pounds. She had a sleeve. You know, a year later she comes back for her follow-up at 136 pounds. And I'm like, who are you? I've never even seen you before. That's pretty common. Not everybody only has one operation. This woman had a sleeve operation, and when she went from 300 pounds to, got cut off, but that says about 220. But she was having terrible reflux after her sleeve, and the sleeve surgery can sometimes make reflux worse. So she had another operation in October of 2015. I converted her into a gastric bypass, and probably at least 10% of people who have sleeve surgeries will go on to having a gastric bypass down the road or some other extra operation. But now she's 190 pounds. She brought her baby in. She's one of the ladies in the slideshow with her new child that I'm not going to get to show you tonight. And she's very happy. Another patient before surgery, it says 280 pounds there, over 300 in a wheelchair when we first got started. Then, let's see, sorry, this was before and this was after with her daughter. Another patient, this is a woman who's not very tall, so she's only 213 pounds, but her BMI is 43, so she had a sleeve, and then afterwards down to 146, BMI of 27, normal again. So another patient before, BMI of 52, 370 pounds, had a sleeve. A year later, down to 230, so that's what was that, 130 pound weight loss. And she has a baby now too, had her baby last year. There she is, 5-week-old son. I don't think she named the baby David, but you should think about that. And this is important actually, that she had been having miscarriages for several years previously. So if you're a woman and you're gonna have surgery, you need to think about and prevent having a baby for at least a year after surgery. Because while you're losing weight for the first year after surgery, you don't want to try and support a pregnancy also. Those two things don't go well together sometimes. Although most of the time, in fact, every experience I've had is that women have healthy, straightforward pregnancies and the babies are healthier than if they had been born before the woman had surgery. Next slide. Before, after, before, we operate on men too. Larry, after, so we went from 310 to 190, he had a sleeve. Another lady with a baby. Not everybody sends me appropriate pictures. You don't have to send me those. Who has doubts about surgery anymore? The answer is pretty much nobody. Who endorses weight loss surgery? Pretty much everybody. So the National Institute of Health, that's why I said who makes Medicare guidelines, and that's why this is a Medicare covered operation. American Diabetes Association, International Diabetes Federation, American Heart Association. Remember 20 years ago, American Heart was all about don't smoke? Now they're all about take a walk and lose weight. That's their major goal anymore. The ASMBS is the association of surgeons that supervises bariatric surgery in this country. We're an accredited program. There's a great deal of scrutiny and supervision over these weight loss surgeries that are done in the United States. And to be an accredited program, you have to go through a lot of work to get your hospital ready to go. We've just passed our second accreditation a couple months ago, and we're very happy about that. So if surgery is so great, who shouldn't have surgery? There's a few people who I might say you shouldn't have an operation. If you're really, really big, and we do BMI of more than 60 all the time, but occasionally I'll see someone with a BMI of 80 or 90, like 500 or 600 pounds, and I'll say, maybe you should have your operation at a hospital that has a bigger ICU, like a university medical center like Stanford or UCLA. Maybe once a year we have to do that. People who have unrealistic expectations of surgery, they think I'm going to make them into a Barbie doll or fix the other parts of their life that need fixing. I can't do that. I can help you to curb your appetite and make your stomach smaller, but fixing your life and the other things is something that you're going to have to take control of. People who are actively smoking, I will not operate on. If you're smoking, you have to stop, because smoking plus surgery leads to ulcers, which leads to coming to the emergency room in the middle of the night, and it's always on Saturday night at 2 in the morning, and then I'm grumpy. So no smoking plus surgery. If you're actively using alcohol or other drugs, you need to stop that, because those things don't go well with surgery. If you have untreated emotional illness like bipolar disorder, or you're depressed, or someone in your family's recently died and you're dealing with all these other issues, divorce, loss of a house, whatever, you need to get those things fixed up first. Most of the time, people who see me take at least 3 months and sometimes as long as a couple years to get to their surgery. So it's not like we have our lecture today and you go to the operating room next week. This is a process that we work through. If you have out of control high blood pressure or diabetes, you have to get that stuff sorted out first. And remember Dr. Dawes, who was here earlier today, if you don't have your own primary care doctor to help you with that, and you should all have a primary care doctor, Dr. Dawes or someone else will help you with it. So this is a picture of a stomach ulcer. You guys can't probably tell, but this is the liver lifted up here. This is the connection between the intestine and the stomach, and you can see there's a hole that's about that big in the front of the stomach where the ulcer perforated through and made an emergency, and that person would die if they didn't have an operation in about a day or two. It's the same as perforated ulcer surgery from a long time ago, and so I have to close that hole and put in drains, and they're in the ICU for a long time, and it's a pain. So don't smoke. This is our hospital across the street. The Marion Regional Medical Center is an accredited bariatric surgery center. We're a Blue Distinction Center. That means we can take Blue Cross and Blue Shield and all of that. And there's actually 3 hospitals on the Central Coast that are all Dignity hospitals. French Hospital, Arroyo Grande, and here. And all those hospitals send all of the bariatric stuff, all of the weight loss surgery stuff to this hospital. This is the center for these operations on the Central Coast, anywhere really between the South Bay area and Ventura. There's 3 operations that we do, but I really don't do lap bands anymore. Did anybody come here wanting a lap band? Okay, this is a lap band. I keep one in my pocket to show to people. It's a rubber ring that's like a napkin ring that goes around the top of your stomach, and it's attached to this tubing and this port that lives under your skin that I can poke a needle into and adjust. I take a lap band out of someone roughly once a month, but I haven't put one in about 3 or 4 years now because they don't work very well. And I'll show you a little bit about that. But if you came wanting a lap band, more likely I'm going to tell you that you should be thinking about having a sleeve operation. The sleeve surgery is more surgery than the lap band, but it's much more effective. The gastric bypass, as I said, is the bigger surgery, the most effective surgery that we do. And I do roughly half sleeves and half bypasses anymore. So to review these, the gastric bypass divides the stomach into 2 pieces. And then the intestine gets divided and a piece of the intestine is brought up and sewn to the stomach. And the food goes down into your small stomach pouch, which is about the size of a hard-boiled egg. And then it bypasses your stomach and goes down this intestine where you digest it. And you don't digest it until down here. So we've bypassed the first 100 centimeters or so of your intestine, and food is digested in the bottom portion of your intestinal tract. So you eat less because your stomach is only this big, and you absorb less because we bypass about this much of your intestine, that much. The sleeve operation is removing the side of the stomach but leaving the normal direction of food in the stomach and then in the intestine, and we don't mess with the intestines at all. So here you absorb everything you eat, but you eat less. And your stomach is about the size and shape of a banana. Should have called it the banana operation. It would make more sense, but it's supposed to look like a shirt sleeve, so it's called a sleeve surgery. In Spanish, it's a manga operation, which makes even less sense. And then this is a lap band, which I said I don't do. So the gastric bypass is the most effective surgery. People lose 70 or 80% of their extra body weight. So extra body weight means if you're 100 pounds overweight, you'll probably lose 70 or 80 pounds. You're not going to lose 70% of your total weight. Food isn't absorbed until it gets down below where the connection is. So there's some things that aren't absorbed very well. Calcium and vitamin B12, and for some people iron, are not absorbed very effectively after this surgery. So you have to take a supplement for the rest of your life. If you're a woman, you probably have to take calcium and iron anyway, so maybe it's not a big deal. But everyone who has a gastric bypass has to pay attention to their diet and take a vitamin supplement for the rest of your life. I don't really think that's a big price to pay or a big deal, but for a lot of people, they're worried about that. If your stomach's only this big, you have to pay attention to your diet anyway, because if you fill your stomach up with Cheetos and Diet Coke, you're going to get malnourished and end up screwed up down the road anyway, because you're not getting proper nutrition. So if your stomach's only this big, you have to fill it up with good, high quality, high nutrition food, and we're going to teach you what that is and how to do that. But most of you already know that it's mostly protein, it's usually fresh vegetables, and sometimes some supplements. But it's generally not potato chips and the In-N-Out burger meal that I showed you before. Advantages of gastric bypass: the weight loss is really excellent, 75 or 80% body weight loss. You can eat normal food. The results are excellent for 10, 20 lifetime years. We know that for doing these operations for a long time. The disadvantages are that you don't eat very much at any one meal. You can get nutrient deficiencies if you don't pay attention to your diet over the long term. The complication rate, having a leak or a problem or a twist or something that brings you back to the operating room emergently after surgery, is about 1 in 200 or less, about 0.5%. And our leak rate here is just about exactly that for complications from this surgery. The surgery is actually not any safer than the sleeve surgery, although it's more complicated. The risk of having a complication is about the same for either one. So don't make that the reason why you choose a surgery. The sleeve operation, where we remove the side of the stomach and leave the narrower banana-shaped tube of stomach and then leave everything else downstream, is a little bit shorter. A gastric bypass takes me about 1 hour and 15 minutes. A sleeve operation takes me a little bit less than an hour. But because it's faster doesn't mean it's necessarily simpler or safer. It's just a different operation. This very long staple line here along the stomach can leak or things can have problems with it. But in general, doing this makes you feel full sooner after you eat a smaller meal, usually that much, say half a sandwich or a cup of soup or 4 or 5 bites of sushi. If you eat more than that, you usually get chest pain and some people actually throw up, but most of the time they stop eating. But then you do absorb everything that you eat. So if you're already on medications that you have to stay on forever, like arthritis medicine, or if you have ulcerative colitis or bad depression and you're going to need medications forever, this might be a better choice because you can guarantee that you're going to absorb everything that you eat when you take it, so that your absorption will be better. This is sort of like the medium operation. Gastric bypass is big, sleeve is like medium large. I don't really do a small operation anymore. For whatever reason, the sleeve surgery works better for men than for women. And the weight loss profile for men is generally more weight loss faster. So oftentimes, if I have a man and a woman and they're the same age and the same overweight, I'll tell the man to have a sleeve and the woman to have a bypass, because then they'll have more equivalent outcomes. The sleeve is not quite as good for diabetes if you're on insulin as well. If you're on insulin for diabetes, I'm going to recommend you have a gastric bypass most of the time. There's the lap band, not doing them. That's why I'm not doing them, because we took a lot of them out over the past 10 years. So to remind you, the gastric bypass is the biggest tool, biggest hammer. Sleeve is more like the medium-sized hammer. Lap band was too small a tool. It didn't really work enough for us to be enthusiastic about it. Every patient has different needs and parameters. So I wrote here that the gastric bypass has more risk than the sleeve. That's not really true. It's about the same risk. The bypass is a little bit better weight loss than the sleeve, but it changes your diet and your absorption a little bit more. The sleeve and the bypass at this hospital both cost the same if you're a self-pay patient. Insurance doesn't care. As I said, I don't really recommend bands anymore. If you wanted a band, I'm probably going to point you towards a sleeve. If you have a lot of weight to lose, or you're on insulin or bad reflux, I'm going to tell you probably to have a gastric bypass. Any surgery has risks. Anything that I can do to you comes with a small risk, okay? There's no such thing as surgery without risk. The risks are very small, 1 in some hundreds or even less than that. But anybody can have bleeding or an injury to something on the inside that creates a problem that requires another surgery to fix. Open, meaning making an open incision instead of doing it through those 5 little laparoscopic incisions. A leak or an infection inside that requires another surgery can happen to anyone, although we haven't had one in quite a long time. Knock on wood. A blood clot that can form in your leg during surgery and then break off and go to your heart and block up your heart or your lungs can happen. That's called a pulmonary embolism. We're terrified of those. I put everybody on blood thinners either before or after surgery. We haven't had a pulmonary embolism in more than 1,000 operations here. We did 1,060 so far as of last week. Anyway, again, we take a lot of precautions, but bad things can happen. That's the point. Death is possible, although it's extremely unlikely. We've had 2 patients die related to surgery here in the 5 years and 1,000+ operations that we've done. They were both men. They were both approximately 45 years old. They both had sleeve surgeries. One of them had a heart attack 7 days after surgery, and one of them had a brain aneurysm explode about 2 weeks after surgery. And so those aren't things that are directly related to the operation itself. It's not like the operation broke, but the stress of the surgery and the anesthetic caused something to happen in them after surgery, so we have to take the responsibility for that. So the point of that is, don't have surgery if you can avoid it. If you can lose weight any other way, I represent risk or harm that could happen. So the lesson there is this, if I can make it work. Uh-oh. We're stuck on risks. Carrie, you might have to advance it manually. Oh, no, I turned it off. Whoops. Haha, fixed it. So you should only have surgery if you can't lose weight any other way. If you can do the cabbage soup diet or the Dr. Dawes ideal protein diet and get to where you want to be and stay there, stay away from me. That's fine. I have plenty of work to do. This is a decision that you make. It's not a decision that I'm telling you. I'm not saying you should have surgery. I'm saying this is a tool that I can offer you, but you have to use that tool correctly. If you don't change your life, if you don't change what you eat and how you eat and when you eat and who you eat with and what your wife puts in the fridge for you and what you did on your lunch hour and with your weekends, you may not get the result that you're looking for. And if you're not going to do that, don't bother to have the operation. Don't accept the risk unless you really want the rewards, right? So here's a patient who had a leak. Carl had a complication. He had a leak where the stomach and the intestine came apart and there was an infection that started up in his abdomen. I had to take him back to the operating room 2 more times. He had a bunch of extra endoscopies where I had to put a scope down his throat to try and fix that. And he was in the hospital for more than a month, I think, altogether. And he was on TPN with IV nutrition going in his veins at home for a couple weeks. And ultimately, he did great. And all of the leaks, and I think we've probably had roughly, I have to count, I think it's 8 in the lifetime of the program so far have done fine. Carl lost 120 pounds after 8 months, and that's what he looks like when he comes to clinic now. He's a happy guy. But, it wasn't a smooth, easy, come into surgery, go home 2 days later and on with your life kind of event for him. This is another patient who had 6 repeat operations after her leak. Now, she was a revision. I didn't do her first time surgery, but I was trying to fix something that was broken from a previous operation. And redo operations, revision surgery, whether it's fixing a gastric bypass or taking out a lap band or doing something else, is higher risk than first time surgery. So she had all these different episodes, 10 days in the hospital. She had a feeding tube that stuck out of her belly for like 3 months before I could take that out. But she's now a volunteer here, and she wears a green shirt, and she'll probably visit you in the hospital afterwards. She's one of our most enthusiastic patients. Another patient, young woman who had a leak after her gastric bypass. She was in the hospital for 10 days. Ultimately, lost more than 150 pounds, and she looks great. And later on in the show, I'll show you her belly so you can see that the scars don't really add up to much. This is our operating room team. There's me, there's Dr. Felix, there's Dr. McCloskey. Kevin Mounts is our nurse first assist who does every single operation with all of us. And he's done cumulatively more surgery than all of us now together. This is a bunch of slides about the data that I was trying to tell you about before. The data that shows that weight loss surgery really works and is effective and is safe. This is a paper from Journal of American Medical Association from 2012 that came out of a group of patients in Utah, almost 1,200, more than 1,000 patients who had gastric bypass. And what they showed is that gastric bypass works better than diet plus exercise plus insulin. And then if you diet and medical therapy, your diabetes never goes away. But if you have gastric bypass, the majority of the time your diabetes gets better and goes away. This is another study that came, this is kind of a famous paper published by Dr. Mingrone showing that if you do diet and insulin, your blood sugar levels remain high without ever going down. If you have a gastric bypass, your blood sugar levels at 2 years actually go to normal pretty quickly. And there's a third operation called a biliary pancreatic diversion. That's also called a duodenal switch. Anybody ever heard of a duodenal switch or a DS? So a DS is another less common operation that's really good for diabetes, but I don't do it because it has increased issues with absorption and causes malabsorption and other medical problems that we don't like taking, that we think are not worth it. So if you look at this paper here, this is published by Dr. Hutter from Harvard, and they looked at a lot of patients having sleeve surgeries, and what they showed in this paper here, I'm going to show you the picture of it, is that lap band patients lose some weight, sleeve patients lose more weight, and bypass patients lose the most weight. And he's showing BMI, loss of BMI, sorry, let me go back. Went the wrong way. What Dr. Hutter showed in this paper is that after 12 months, sleeve patients had lost about 11 BMI points, and bypass patients had lost about 14 BMI points. And if you look at our data from here, what you can see is that our patients are doing either the same or better than patients who are published from large volume university hospitals. So this is gastric bypass patients 3 years out from surgery here in Santa Maria, where the average starting weight is 293 pounds. And after 2 years, they've fallen to 189 pounds, which is actually better than the weight loss in the paper that I just showed you. And then at 3 years out, people have regained a little bit of weight and gone from 189 to 202. So a lot of people experience late weight regain, where they put on a few pounds 3, 4, 5 years later. And that's usually because they got kind of lazy and aren't doing as much as they used to because the excitement of surgery is worn off. Sleeve patients lose a little bit less weight. They go from 273 to 194 and then also regain a bit of weight. And then patients who are having a revision of their operation, changing one thing into something else or fixing a gastric bypass, generally do very well with, here it is, 235 to 166 pounds. So this is a slide I'm really proud of, and I think that you can sort of figure out where you fit on these curves. Dr. Hutter's data. This is data from a guy named Dr. Phil Schauer. Dr. Schauer is probably the most prominent bariatric surgeon in the United States. He's at the Cleveland Clinic now. He's the one who trained Dr. McCloskey, my partner, who you may be working with if not with me. And what his data shows is that medical therapy at 3 years out doesn't do much for you. His sleeve patients lose about 8 BMI points, and his bypass patients lose about 10 BMI points, and then regain a little bit after 3 years. And so again, our data is similar to that, actually a little better. There's our beta. This is looking for, let's see, that's weight loss. I showed you that. This is the same slide again that looks at what happens to your blood sugar levels, and those are actually normalizing. And this is looking at hemoglobin A1C, which is another measure of blood sugar levels. This is a paper that shows that lap bands don't work. I'm going to skip it. If you look at what happens to medical problems after surgery, after gastric bypass, this is Dr. Shower's data. I told you I showed you one of his graphs. So 1 year after gastric bypass, if you had high blood pressure, 70% of people's high blood pressure is cured. 80% of people's diabetes is cured. 60% of cholesterol, 75% of sleep apnea, 70% of reflux are all cured. Asthma tends to get better but doesn't go away. Arthritis tends to get better but only gets, if you've already worn out your knee, the surgery is not going to fix the cartilage in your knee. But most of these medical problems, diabetes, asthma, leg edema, cholesterol, sleep apnea, high blood pressure, reflux, arthritis, improve or go away completely. This is the same information presented a different way and looking at sleeves. So band surgery gray, sleeve surgery blue, bypass surgery green. If you have diabetes, bypass cures diabetes in 80% of people. But the sleeve isn't quite as good. That's why I said if you're on insulin, probably you're going to pick a bypass. High blood pressure, similar. Sleep apnea, about the same. Reflux, a little bit better with bypass. So to review, bypass, bigger surgery, more weight loss, better medical issue resolution. Sleeve, medium, lap bands, don't do them. Any surgery is just a tool. If you don't change your life around using this tool, you will not have as good an outcome. I think I've already said that. Surgery is the springboard to changing your life. It's like you're going to jump off a diving board and you got to figure out what the dive's going to be, but you have to swim afterwards too. If you just go off the diving board and don't do anything, you will not have the result that you want. Our program consists of me, Dr. McCloskey, Dr. Felix, Carrie Smith is our nurse. We have our own nurse practitioner, Nurse Anna, who you will all meet with. We have our own dietitian. Brianna Wilson has left us, and we have a new dietitian whose name is Meg, who's starting next week, who's terrific. We are, as I said, a center of excellence. That term isn't really used anymore. We're now called an accredited center. We're a Blue Cross Center of Distinction. I got to fix that slide there. Don't tell on me. I only operate at Marion Hospital across the street. If you go to French Hospital or Rio Grande with an emergency or something and it's related to one of the surgeries that we do, they'll have you come back here and we'll take care of you in this hospital. This hospital was built in 2012. It's a new facility, has 200 beds. It's really super nice hospital, and it was kind of purpose-built for doing weight loss surgery with wide doorways and big wheelchairs and heavy-duty everything. So it's ready for big patients. This is some of our clinic staff. There's Nurse Carrie. There's some of our front office staff. There's Dr. Felix. That's me. That's Dr. McCloskey. That's Dr. Felix. That's Nurse Carrie. That's our operating room team. We have all new operating room stuff for doing these surgeries, although it's been used 1,000 times now, so it's not quite new anymore. All the patients have private rooms in the hospital upstairs. They're a lot bigger than they look. We have our own dietitian. We have our own mental health provider. Your surgery, your insurance company will likely require you have a psychiatric evaluation or a mental health exam before having surgery. We'll do that for you in our clinic. We have someone who does most of those. We have our own pharmacist who will go over your medications after surgery. We have the wellness center next door for learning how to exercise again. We have educational seminars twice a month here, plus once in San Luis Obispo, plus once in Lompoc every month. So we're trying to do community outreach for education. We have support groups if you want to meet patients and have me not be there and do all the talking. That's fine. Most insurance covers surgery. Medicare, Medi-Cal, Blue Cross, Blue Shield, Western Growers, Aetna, Cigna. Did I miss any? TRICARE. Yeah, Medi-Cal, CenCal, all of those. If you do not have an insurance product that covers surgery, These numbers are wrong. Surgery here costs about $15,000, give or take. And that is, I can guarantee you, the cheapest for legitimate surgery you can find in this state. And if you're foolish enough to go to Mexico to get a cheaper surgery, don't come to us with your problems afterwards. What do you need to do? The first thing you need to do is call your insurer and ask if you have bariatric coverage. If you have Anthem Blue Cross, in-state, if you have Medi-Cal, Sen-Cal, Medicare, or any of those other ones, it's almost certainly going to be yes. But if you have an insurance product that I haven't mentioned, or you have a small product, call and find out first, because not every insurance company will pay for weight loss surgery. Then you should see your doctor and tell them that you want a referral. Because as I said, you should have a primary care doctor who's managing your blood pressure and other issues. If you don't already have a doctor, we'd be happy to see you anyway. We won't turn you away, but we will help you get established with a physician in addition to starting your bariatric surgical workup. Generally, it takes at least 3 months to get into the operating room from the time you start. Sometimes it takes a lot longer. Everybody's going to come to this lecture. Everybody's going to meet with me or Dr. Felix or Dr. McCloskey. Everybody's going to have many months of dietitian visits. If you have Anthem Blue Cross, they require that you do 6 consecutive months of diet visits before they'll let me do your surgery. So you have to meet with our dietitian 6 times in a row without missing any months. So it's March if you start, or now it's April. April, May, June, July, August, September. You could have your surgery at the end of September or October if you started this month. That's generally what they mean. Medicare requires 4 months. Sen-Cal requires 1 month only, which is nice, although everybody gets 2 or 3 visits anyway. Everybody gets labs. Women over 40 get mammograms. Everybody needs a colonoscopy if you're over 50 and you haven't had one. If you're over 55 or you're having trouble or you're in a wheelchair, I'm going to make you get a cardiac stress test or some kind of exam of your heart. If you're smoking, I won't operate on you, so we'll have to help you fix that. Everybody comes to the educational seminar. Everybody gets a psychiatric evaluation. Everybody meets with our nurses at least once and sometimes many times. Once you're ready, you get this big 3-ring binder full of information that has about that much stuff in it, and you have a whole nother nursing visit that lasts a half a day where you go through it all again, and there's actually even a quiz at the end of it, although no one's ever failed. I generally do surgery on Mondays. Most operations take me between an hour and 2 hours. I usually do 5 or 6 operations per day. About half of people go home on Tuesday, and the other half of people go home on Wednesday. So most people are in the hospital overnight, sometimes 2 nights, but you'll stay in the hospital until you're ready to go home, however long that is. Most people are up and walking around on the day of surgery. A pharmacist will meet you in the hospital after surgery to go over your medications. A dietitian will meet with you again. You'll see me a lot of times. You'll see Nurse Carrie a bunch of times. And you'll be up and walking around and pretty quickly feel pretty good again. This is a reminder, if you're having surgery with me, leave me at least 1 fingernail to put the blood oximeter device on. Last year, I had all these ladies go and get all these pedicures and manicures, and then they all came to the hospital with beautiful fingernails, and we couldn't get their oxygen levels. So leave me 1 fingernail. Otherwise, we've got to put on your privates. Walking around and drinking right after surgery. Sorry, I'll stay still. I want you walking on the day of surgery because being upright makes your lungs expand and helps prevent pneumonia, keeps the blood going in your legs, and prevents those blood clots. Those are the big things that we're scared about after surgery. Most people go back to work within a week or 2. It kind of depends on what you do. Some people take more time, especially if you're heavy lifting or doing a lot of like patient care stuff. But I've done easily a dozen operations on nurses and staff in my hospital, and virtually all of them have been back at work the following week because they're motivated and want to return to work. Kind of depends on what you want. If you're on birth control pills, I want you to stop those a month before your surgery to reduce your risk of blood clots. Women with estrogen patches, the same thing. I give you blood shots while you're in the hospital to keep your blood thin so you don't get those blood clots, but you don't have to do that at home. And if you're up out of bed and walking around right after surgery, that blood clot risk falls to 0 very quickly. What do you do after surgery? Well, you're walking around. You come and see me after 1 week, and then after 4 weeks, and then after 3 months, and then after 6 months, and then every year for the rest of your life. So the follow-up after surgery is very intensive to make sure that things are going well. A lot of people after 1.5 years have that saggy skin and end up wanting a tummy tuck, which I do more and more of. So this is going to be a disappointment because Tyler's post-paniculectomy picture isn't here. That's before surgery, that's the day after surgery, that's the saggy skin, and there's supposed to be a slide here of after his tummy tuck, which I don't have, sorry. But this is other patients walking the halls after surgery. You can see they got their little leopard fuzzy slippers on and they're going up and down. So I really want you out of bed moving around right after surgery. This is what incisions look like right after surgery. I usually staple them shut with little metal staples. Each one of those is about this big. This is what those scars look like a couple months later. Remember when I said there was that woman who had the complication and had to have a second surgery the same week because she had a leak? This is actually her belly. So you can see the scars are almost invisible even after a couple surgeries. Not everybody, you can find their scars at all, right? If you get a bunch of tattoos, I can't see them. This is what redundant abdominal skin can look like. And sometimes that skin is really not very healthy. And when you take it off, it looks like that. This is a 17-pound specimen. But if you look at what her scar looks like afterwards, and that's what her belly looks like afterwards, my point is this. I don't hold myself up as a plastic surgeon. I'm not trying to make people look good in bikinis. But the operations for the tummy tuck, even though they leave a scar, generally are very functional and they leave people very happy because their clothing fits and all the rashes and infections that they're getting go away. So I have a bunch of before and after tummy tuck pictures here. The younger you are and the less you weigh and the younger your skin is, the better your scar will come out. But everybody gets some kind of scar. There's another before. If your tummy's hanging down and covering your privates, in general, I can get the operation done after, before, after surgery and before tummy tuck, after tummy tuck. And that's what her scar looks like. So those are all, that's a pretty common paniculectomy scar. Before, after, with the tummy, after tummy tuck. So men have these surgeries as well. Any surgery can have a problem. This is my thing again. It's very uncommon. Less than 1 in 100 people have a complication. But if you have surgery and you have severe pain, you're short of breath, you have chest pain, your shoulder hurts, if you feel like you're going to die, you got to give me a call. Don't take 2 aspirin and wait till the morning and say, I hope it feels better. I don't want to bother him on a Saturday night. That's not what we want to hear. You either need to come to the ER or you need to give us a call and figure it out pretty much right away. After these operations, you're pretty much through the woods after about 2 weeks. Gastric bypass, you're out of the woods after 1 week. Sleeve, you're out of the woods after 2 weeks. But in general, after a couple weeks, you're safe and nothing bad's going to happen. But in that first period of time, if you're having a medical problem, please give us a call if you don't feel well. Signs of problems: fast heart rate, severe vomiting, pain in your chest, fevers more than 100 degrees, a fast pulse rate, like your pulse is beating really fast, sweaty forehead, severe diarrhea or new back, chest, or shoulder pain. That should prompt a phone call at minimum. Bobby's a volunteer. She had surgery. Will you come and say a couple things?
I have 2 minutes to talk. I'll talk fast. The doctor asked me to come and just present myself. I was at my highest weight, 241, and I'm 5'1.5", so I kind of met the criteria there. I also used a CPAP at night because I had sleep apnea, and I also had hypertension. These are just closer up pictures. My physician recommended that I have the surgery because, like you, I've done everything else my whole life, experienced the up and down, and so I had the sleeve. I started with Dr. Maccabee, but then Dr. Felix actually did the surgery, and that was in June of 2015. And right now I weigh 130 pounds, so I'm actually below. I'm below where I'm supposed to be. The focus is on getting healthy, but I kind of am goal-oriented and wanted to know what I was supposed to be weighing. So, you know, a lot of it's your psychological outlook. I think that's part of why it's been successful for me. And that black binder that you're going to get that he mentioned, you refer to that a lot. That will help you along in your journey so you know what to eat and you won't have any questions. 5 months after my surgery, my hypertension meds, I had 3 done. Before that, the CPAP done. I gave that machine away. I also had bursitis in my hips, and I realized maybe 10 months later, I was like, oh, I don't have bursitis in my hips anymore. So I'm doing a lot of things, you know, I ignored a lot of the warning signs, the red flags, probably things that you've experienced too. But when I knew I was going to be a grandma, that was really my motivator. And I'm going to be a grandma again. I just found out on April Fool's Day. So, you know, and my husband said, oh, you're going to be chasing after two? And I said, yeah, but my hips won't hurt now. So there's a lot to look forward to. This is like a new lease on life. I come and talk at these seminars twice a month, and I also visit in the hospital usually the day of your surgery. I've cut back a little bit, so if you're there on Tuesdays, you'll probably see me. That's usually when I go and just probably more talk to the family than you, because you're going to probably be out of it. You've already been educated enough. But I'll stick around after if you have any questions about food or clothes or reactions from people or anything you might want to know. I'll stick around.
Bobby, thank you very much. I think the next slide is you too. Nope. There you are. So before, well, there's the real after over there, but there's Bobby. Thank you very much. All right. That's our whole talk. If you have questions, the website of the hospital is very good. I keep my own website, but and I have links to YouTube videos and things like that on there. I would caution you about taking information off the internet. A lot of what people put up there is not edited, not filtered, and not any good. So be careful about what you read, and make an appointment if you don't already have one. Good night, you guys. Thank you for coming.
Thank you.